Right. So we have what we call the thoracic cage, right? And the thoracic cage, it's simply the skeletal framework that supports the thoracic structures that are inside, right? So this thoracic cage, I think you can appreciate that there's a bone here anteriorly, which we call the breastbone. Anatomically, it's called the sternum. Yeah. So we have the breastbone or the sternum. Then going anterolateral, also going posterolateral at the back, we have the ribs and their costal cartilages. Then posteriorly, we have the thoracic vertebra. They are 12 in number. So named thoracic because of their region. Remember, we had 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and a coccyx, right? And this thoracic cage has an inlet and an outlet at the bottom part there. So it really depends with who's talking. Is it from anatomy? Is it from surgery? So this top part here can be an inlet. It can also be an outlet, right? So you don't. So to avoid that discrepancy in terms of words, we call this the superior thoracic aperture, right? Aperture meaning a hole or opening. So superior thoracic aperture, and then inferior thoracic aperture lower down there. The inferior thoracic aperture is larger, but in life, it's closed by the diaphragm. Then the superior thoracic aperture is the one that is, um, yeah, the smaller one, but it's not closed. In terms of shape, does anyone know the shape of this superior thoracic aperture? Since we are 2-3, I think you know that it's I'm referring to you guys. Does anyone know the shape of this superior thoracic aperture? Christina, you unmuted. Did you want to say something? Okay. So anyway, it's bean shaped. If you know a bean, your normal traditional African beans, right? That bean shape, or we can say kidney shaped, or we can even say reniform shaped. It's referring to the same shape, right? Boundaries for this superior thoracic aperture. Anteriorly, there is this part of the sternum, or the superior part of the sternum. This part is called the manubrium sterni. So the superior border of the manubrium sterni forms the anterior boundary. And then the posterior boundary, we have T1 vertebra, thoracic vertebra number 1. Then laterally, we have the inner border, or we can call it the medial border of the first rib, right? Then inferior thoracic aperture is the one that is closed by the diaphragm lower down there. So I won't talk about it for now, right? But since there is something that closes, for structures to move from the thorax to the abdomen or vice versa, those things will need to pass through the diaphragm. So the diaphragm will have openings for things like the esophagus, the inferior vena cava, you name it, because it's closing off or it's walling the thorax above from the abdomen below, right? Okay. So the bones that really make up this thing. So here we have the sternum. The sternum, which is our breastbone, it's made up of 3 parts. There is the manubrium sterni, there is the body of the sternum, then there is the xiphoid process here, right? So this manubrium, Can you see here? There's a jugular notch here. You guys have done head and neck. What do you remember of this jugular notch? Anything that you remember? Do you remember anything about the jugular notch? Or maybe you remember the word suprasternal notch? Still referring to that notch up here, on that level there. What do you remember about the anterior jugular veins forming a jugular arc when you're doing head and neck? So the bad thing with learning anatomy by regions is you tend to compartmentalize things and you find it hard to join the dots. But just remember, this is the jugular notch, um, and the sternum articulates with these costal cartilages from the ribs. So the attachment for the first rib is on the manubrium. Then the attachment for the second rib is shared between the manubrium and the body. This other site here is for attachment of the clavicle. Remember, there's a sternoclavicular joint. When you're doing upper limb, sternoclavicular joint is a synovial double plane joint because it moves in two planes. It allows for retraction and protraction, as well as elevation and depression. And in terms of joint type, it's it's a synovial pseudo joint, right? So that's your manubrium. Then this is your body. So the body will have a demi facet. Demi means half. Demi facet for rib number 2, because remember I said the other half is on the manubrium. Then third, fourth, fifth, sixth, and sometimes the seventh, they are on the body of the sternum. Other people say that the facet for the seventh rib is on the xiphoid process, but for the reference book that we use this side, it says that the xiphoid process um, does not have an articular facet for costal cartilages of ribs. But either way, when you then look at the bodies or the cadavers, you see it there. Okay, so I don't know what you guys will see in your book, but for the purposes of this video, let's just say that all the other facets are on the body, right? So the body is thinner compared to the manubrium. You can appreciate that it's longer. I always use an example that if someone is tall, they are more likely going to be thin. If someone is short, they are more likely going to be thick. Look at your friends and you imagine like what I'm trying to say, right? So the body articulates with the manubrium at this joint here. We call the joint the manubrio-sternal joint. Anatomically, you see a crease on your skin that we call where we have the sternal angle. So in terms of vertebra, this manubrium is opposite T3 and T4 vertebra, right? Such that this joint, the manubriosternal joint, if the manubrium is opposite T3, T4, the manubriosternal joint is now opposite the intervertebral disc between T4 and T5. There's a reason why I'm giving emphasis to that. Because at that sternal angle, there are more than 8 thoracic anatomic landmarks. For example, the arc of the aorta, as it arcs from the ascending aorta of the heart, starts to arc at that sternal angle. It's just an example that I've given. And so for now, just remember that sternal angle is at the manubriosternal joint, and it is opposite intervertebral disc T3, T4. Right. So that's the body. Right. Then this is the xiphoid process. Right. It's not constant in terms of size and shape. Sometimes it appears bifid, can be divided into two. Right. Okay. Then problems that can happen here embryologically. You can get what we call pes excavatum. I struggle with pronouncing that word. I don't know. Let me use text to write this. It becomes easier for me. So pectus excavatum. Was that the spelling? Then there's pectus carinatum. The spellings are bad, but you can get the picture. So to remember this, one of those conditions, the sternum is sinking inward. The other condition, the sternum is coming out. Right? So if you remember, what is to excavate? You're digging in, right? So pectus excavatum, this is where the thoracic cage sinks inward, right? And it's also called let me put brackets. It's also called a funnel chest. Right? Then your pectus carinatum is a chest that is bulging out. That's what we call a pigeon chest. So sometimes you see those boys who are, walking with their chest out. Sometimes even though you know they're doing it for the swagger and what, sometimes it's for as a medical personnel, try educate them about some of these things because they may have dire consequences as you age. And some of them will actually be sick, and you'll be thinking that it's people who are doing it out of their own will, but it's not always the case. Right. Okay, so that's your sternum. Then you have 12 ribs. So ribs, there are two classifications of ribs. There's an easy one where you simply classify your ribs into true, false, and floating. So true, false, floating. Then the other one, which really now looks at the structure of a rib, we classify ribs into a typical rib, that with all the typical features that a rib should have. Then we have an atypical rib. Just a moment. Right. So, well, what I was saying is we can classify ribs into true, false, and floating, or we can classify the ribs into a typical and an atypical. Typical is a rib that has all the characteristics that are supposedly ascribed to a rib. Then those that are atypical, they have unique features, or they lack the features that you see on the other ribs, right? So that one is now structure based, which is the picture here. But the first classification that I told you, we just use this picture here, right? So what we call a true rib. A true rib is a rib that articulates with the sternum. By articulate, I mean that makes a joint with the sternum using its own costal cartilage. For example, rib number 1 here uses its own costal cartilage to articulate with the sternum. Rib number 2 does the same, 3 the same, 4 the same, 5, the same. 6, yes, the same. 7, yes, uses its own costal cartilage. But look at rib number 8, number 9, and number 10. Their costal cartilages are joining the costal cartilage of rib number 7 before they go to the sternum. So rib number 1 through to rib number 7, those are true ribs. Rib number 8, 9, and 10 are what we call false ribs. False ribs articulate with the sternum indirectly, meaning their costal cartilages, they join the costal cartilage of the rib above before going to the sternum. Then rib number 11 and rib number 12, we call them floating ribs for the reason that they do not articulate with the sternum. They don't even reach the sternum. I think you can see that this is rib number 11 and rib number 12. They're just floating there, right? And that poses harm or danger to abdominal viscera. Because when we do abdominal organs, we find that, for example, the spleen is related to the 9th, the 10th, and the 11th rib. The kidney, if you're on the left side, it's related to the 11th and the 12th rib, which are the floating ribs. If you're on the right, it's only related to the 12th. So these ribs, they pose danger to things that are in the abdomen in cases of trauma, right? Because they are floating. So imagine if something happens, something traumatic, they are more likely going to pierce through organs, right? So we have true, 1 to 7, false, 8 to 10. Then we have floating, which is 11 and 12. Right. Having done that, we'll now come to the proper anatomic classification of ribs, where there is typical rib and atypical rib. Then again, it depends on text. Other texts, they say rib number 1 is atypical, most rather, which is true. Then rib number 2 is controversial. If you use other books, they say it's atypical. Other books say it's typical. So if you're using Snell, I think Snell says it's typical. Then if you're using other books, it says it's atypical. But for now, we'll use atypical. Right. So for you to be able to see that a rib is atypical, you need to be able to define a typical rib. If you're able to navigate your way through knowing what a typical rib looks like, only then can you know what's peculiar about another rib. Right, so I'll use this rib. I've always used this. I think it's rib number 5 somewhere here. Yeah, this one. Right, so this is your rib number 5. It's a typical rib. So we'll start with this end here. This is where we have the head. The head of a rib will have 2 facets. Right. Why 2 facets? So get me right. For a rib, for example, rib number 5, the reason why it needs 2 facets, one is for articulation with the vertebral body at its level, meaning vertebral body T5. Then the other one is for articulation with vertebral body above it, which is T4. So for a rib, a typical rib, the head has 2 facets. What are the 2 facets for? One is for articulation with the vertebra at its level. Then the other one is for articulation with the vertebra above. Right. So that's the head. Then there is a neck. The neck has is that part there. Then there is a tubercle. The tubercle has an articular part and a non-articular part. The articular part there will articulate with the transverse process of your thoracic vertebra. So already you know that the rib has three sides where it articulates with the vertebral column. So a typical rib should articulate with the vertebral column at three sides. Two of the sides are at the head, then the third side is at the tubercle. I prefer calling that joint the TT joint, double T. Why? Because it's a joint between the tubercle of the rib and the transverse process of your vertebra. The proper anatomical name for that joint is costal transverse rib. Costal means rib, right? So all those three joints, they are synovial joints, right? Then I think you can appreciate that this is the shaft. This rib is long. There's a mnemonic that I usually use for a rib. We say KIT. Right. So the rib is going to be, the shaft is going to be curved, it's angulated, and it's twisted as well. Right. So KIT, it's curved, it's angulated, and it's twisted. Right. Okay. So typical ribs are rib number 3 to rib number 9. Those are what we call typical ribs. Right. Rib number 1 and rib number 2, they're atypical. This is rib number 1. Let me show you. This one, yeah. This is rib number 1. This is very short. Don't need even to be told. This is rib number 2. It's also a bit shorter. It's just times 2 the length of rib number 1, and its superior surface is rough. The superior surface for all the other typical ribs is smooth. Right. Okay. Then rib number 10, 11, and 12, they're atypical. Though not shown here. Rib number 11 and 12 will not have a tubercle. So they will lack the joint between the tubercle and the transverse process. On top of lacking that, rib number 11, 12 plus rib number 10, they have one facet on their head. Unlike the typical ribs where there were two facets, one for articulation with vertebra at its level and the other one for vertebra above it, rib number 10, 11, and 12, they only have one facet for articulation with the vertebra at its level. It does not articulate with the vertebra above. Right. Okay. So yeah, I'm trying to keep it simple. Then thoracic vertebra, I know we have talked about thoracic vertebra when we're doing back, but I'll just give a rundown. It's hard for me to go back to back and look for a proper picture, but remember there are 12 in number, and they have a body which is heart-shaped. I remember using the the comparisons of saying that in the thorax there's a heart. So the body of thoracic vertebra is heart-shaped. Lumbar vertebra, I said in the lumbar region there's a kidney. So the body of a lumbar vertebra is kidney-shaped, right? So the body for a thoracic vertebra, it's heart-shaped. They have a small and circular vertebral foramen because the spinal cord is thinnest in the thoracic region. And I'm sure you remember all those things. They have a spinous process which is long. Yeah, basically that's that. But when you look at those thoracic vertebra, we also have typical and atypical. So for vertebra, number 2 up to number 8, thoracic vertebra, they are typical. Then T1, the 9, 10, 11, and 12, they are going to be atypical. So what should a thoracic vertebra that is typical have? A typical one should have two facets on its body. Because if I draw here, this is rib number 5, this is rib number 4, this is rib number 3. So 5, 4, 3. This is T5, T4. Don't mind my bad drawings. T3. So rib number 5 articulates with T5, right? It also articulates with T4 above it. Then rib number 4 will articulate with T4. Then it articulates with T3 above it. T3 will articulate with rib number 3. Then rib number 3 will also articulate with vertebra above. So in that way, you can already tell that a typical thoracic vertebra should have two facets on its body. This time around, the words that we use, one for articulation with the rib at its level, and the other one for articulation with the rib below. For the ribs, we're saying above. For the vertebra, the language is now below. So, clever students, you just remember one, and it's easy to remember that for your ribs, not for vertebra, right? Okay. And remember, I say the transverse process of your thoracic vertebra will form a joint with the tubercles on the ribs, right? And in terms of shape, just remember that those transverse processes are club shaped. If it ever comes up on your exams, right? Okay. Then T1 is atypical because it resembles the line above it, which is the cervical vertebra. That's what makes it atypical, right? Then I had forgotten to mention the costal cartilages, but these costal cartilages are just hyaline cartilage connecting your ribs to the sternum. I remember the types of cartilage. There is hyaline, there is elastic, and there is fibrocartilage, right? So joints, the three joints between the rib and the vertebra, they're synovial joints, right? Then the joint between the rib and the cartilage, it's costochondral joint. Costo means rib, chondro means cartilage. Remember chondrocytes from your general histology. So costochondral rather joint is the joint between the rib and the costal cartilage. That joint should never move. Because if you want to support the rib to the costal cartilage, imagine if it's moving here, yet you want to support that rib here. It's useless. So those joints are primary cartilaginous joints. Primary cartilaginous joints do not allow any form of movement as compared to secondary cartilaginous joints, which allow a slight movement. So these are primary. Then the joint between the costal cartilage and the rib, not the rib, rather, the costal cartilage and the sternum. Right? These are now movable joints, right? And we call them chondrosternal. Right? These are now synovial joints, right? Except the first one here, which also doesn't move. It's a primary cartilaginous joint. You better understand that when you do mechanics of breathing, right? Okay. So I'm saying that it's saying we are left with less than a minute for this Zoom meeting to run out. Um, I think we can rejoin and we continue.